discussing questions. So there are lots of new doctors also joined today, as I know. So just going to give you first 5 minutes brief introduction. We are the company which provides all things, whatever you want to have to crack the exam, provide hard copy book, ebook, online subscription, WhatsApp, Oman, Viva, all exclusive data flow services, short packages, mobile application, Android, iPhone, lots of mock test, which is already available on our website, and excellent recorded videos are also there. It is not just helpful to this DHA that much, but honestly speaking, for various exams, FMGs and all, because concept will not change. So some most of the doctors thinking that it just help for DHA, so it's absolutely not, because the basic concept never change, whether it is MBBS, MD or DM or super specialist. So we are trying to discuss the basic things, and two new feather in our basket is homeopathy subscription and dental, which is going to be launched probably by next 1 to 2 week. So if you have homeopath doctors in Middle East or any part of the world, they can also get the benefit of our expert team. And this is one of uh, the most and one and only subscription we launch right already, right? So probably it will start from first, right? And this is number one. I would like to tell you, this is 100% money back guarantee. If anyone has better than this plan globally, right? Globally, will 100% refund you. You just need to show, sir, this is better than this plan. We did a lot of extensive research and come up just to help the students, because earlier we have a lot of things that okay, it's high cost, blah blah, this that. So just to cope up with that, right? What it includes, this is the best deal ever globally with high yield study material for all prometric exam. This is like whole package. If you take one by one, it is 625 US dollar, which is like $100 now. And it will start from the first date of the each month. So 1st April, it will start limited seat. So you can enroll now, 1st April. This is only 1 month package. So those who are going for short exam, they can go for 1 month subscription, which includes everything. You don't need to now struggle for anything. You have coaching live sessions every day, which supposed to be $300 hard copy book in India. Out of India, we just to have a courier charge. Otherwise, it's in India, it's free. Ebook $25, 1 month subscriptions, video library, WhatsApp subscription, crash course, mock test, mobile applications, high yield point, everything is there. So around 625, 650. Now nothing is left. Three major product. One is coaching. It is absolutely important. The way we are doing every day, our expert team will delivering the live classes. You have hard copy book, you have online subscription. So these are the three main things, right? Earlier, like people are trying to take just 1 month subscription, they are not getting coaching because it's a 300, 400, 500, 350 cost for coaching. So now including coaching, hard copy book and online subscription and many other 10 things, only just once in all, that's it, right? So those who wants to enroll, just contact on this number. This is our support number, 96873780, and this is my number. This is website, our email. So you can enroll in that as soon as possible. We are planning to accommodate just 50 doctors, otherwise it's very difficult for us to accommodate lot of, just to avoid the i mean uh, rush, right? And a lot of people in the class. So we probably make two batches, but like 150 earlier batch, it's almost closed now, because this is like we get a lot of inquiries. And second thing, just for your knowledge, we recently, our company has launched the referral program to those who are referring any students, right? They are not joining, but they are referring, right? Then even though on referral they will get the flat 100, 1000 in this referral bonus to your account in, right, 1000 Indian rupees, right? So this is also a referral program. Anybody refer, they just need to tell us or company that this candidate we are referring. That's it. So this is one referral program already launched, right? And this is homeopath course and this is dental course. So my other team will guide you later on sometime when they are taking lectures. So we are going to start the dental course exclusively in that. Recently, we also established company in Dubai. So we renewed our license, right, in Dubai. So this couple of weeks back, I was in Dubai. So we got the license as well, trade license, right, to work and operation in the Dubai exclusively. This is our team there. locally as well in Dubai. So this is like almost 3 4 weeks back picture, and that's it. And this is Dr. Munjal. Myself is Dr. Munjal, hemato-oncologist and bone marrow transplant fellow. Almost practicing for 20 years in the city and in the corporate, right? So I did extensive work for last 20 years in hemato-oncology. I did my fellowship from Italy, Rome, which is considered to be the biggest transplant center in the world. And we did, I mean, more than 500 bone marrow transplantations in various corporates so far for all indications of blood disease and cancer. And right now I'm also working fellow in couple of corporates. So without wasting the time, this is our team. I'll go very quickly. Dr. Aarti, consultant pediatrician, this Maddie, right? This is Dr. Akanksha, Dr. Maddie, Dr. Meghna, Dr. Sonal, Akanksha, Dr. Ramya, gynecologist, Pooja, Kainath, and Pallavi, everyone knows, right? So this is our things, our hard copy book. This is our various packages. But whatever, and this is one of the unique things to crack the exam. Those who are really wants to crack exam in a short period of time, strong recommendation. Just subscribe this channel. We This is old number. Now we have more than 200 plus videos. Even if you see one video a day, no, believe me, one video a day in 1 month, you are, I mean, close to 1000 MCQ you are solving. Just seeing one video a day. Only one video a day completely. If you listen it well, in 1 month you close to 1000 high yield questions you can solve, right? It is also absolutely high yield. And end of the session I'll get your feedback. You will 100% more than happy. This is our mobile application, Android and iPhone. So not using it, use it. And mock test, I strongly recommend everyone do the mock test every other day or at least twice in a week. So you're gonna get what exactly you are learning, where you are making mistake, why your score is low, what you need to improve, lot of things, right? So that's it. So this is various things. So before wasting the time, let me jump to the first questions. Now our real game starts. So you just concentrate and it would be interactive. See, I will going to handle 100 questions in next 1.5 hour, 100 MCQ, not just an MCQ, 100 MCQ with all basic understanding. So you need to involve yourself, right? And you need to answer it well. You need to interact well. Then you get to know. So first questions in front of your screen, 35-year-old lady complaining of breast tenderness and diffuse nodularity during the physical examination. You found that there is a 3 centimeter tender mobile right side mass. What you gonna do for this patient, or what will you do the next? Are you going to do a FNA with cytology, or you gonna go for mammogram biopsy follow up for the next cycle? You just want to wait and watch, observe. Nothing can be done for this patient. And there are hundreds of questions related with this. So now you have this talk is open for all. You have a facility of chat box, right? So you can answer your things in chat box A, B, C, D. Then we'll discuss. We'll absolutely going discussing. And I selected today only high yield questions only, which is frequently asked in the exam. Yes. So far I did not get any answer in the chat box. So you can you answer it. We are not in hurry. You completely utilize your brain. Yes, somebody is joined with the iPhone. Dr. Anisha, what do you think, Dr. Anisha? Why you want to do FNA and cytology? Let's discuss. Let's open this platform for discussion. We want to understand. Yes, Anisha, if you can answer, I would be happy.
Yes, good morning, sir.
Very good.
Um,
Go ahead.
because there is a palpable breast lump is there, and the woman's age is less than 40. So FNSC will give the much better idea regarding the types of lesion and all.
So just to discuss more, FNA is more sensitive or biopsy is more sensitive? Anybody can interact. Huh? I'm not just trying to tell her. This is absolutely a discussion platform.
Sir, biopsy is more sensitive
More.
He is
So
more
why
sensitive.
somebody is not using biopsy? Why then you want to go for FNA? Just for discussion.
because she has a mobile mask and most probably it's fibroadenoma.
Perfect. So is it benign? Is it malignant? How we supposed to know this is benign or malignant? Is there any clue in this
By
ABCDE?
fixation and mobility.
Okay, so mobile is benign. Is it so every time? I have seen many breast cancer which has a mobile mass, but they are turned to be malignant. I'm seeing at least 5 breast cancer a day for many years. Yes,
Biopsy
please.
will differentiate the malignancy and benign conditions, sir. But
Wonderful.
what we ask
Biopsy
is
will differentiate.
not the appropriate one, what you will do next.
Hmm.
So, as it's a tender mask, I would.
Yeah, you give your answer. Don't worry. This is absolutely learning platform. No? That is why we are here. Right. So what you want to do? Anybody?
Even if you want to go, you will go with ultrasound first, I guess.
Ultrasound. But unfortunately, sir, ultrasound is not in the options.
So
So you have to give. You have to
I think
take the answer from
observation
the options only.
observation would be the answer for this, I guess.
Observation. Now I will. I mean, comment on this. I'm thinking, sir, 35 or anything more than 35, diffuse nodularity mass, right? More than 2 centimeter mass in any female with 35. Are you okay to, I mean, observe this patient, or you need to do at least something for this patient? Is it
The-
suffice observation? Then how long you do the observation? What is the protocol? 1 month observation, 2 month observation, 3 months observation, right? Or observation is really a right things to do for this patient who has a really a 3 centimeter of breast lump.
Yeah, in that I think in that case we'll go for mammogram.
Wonderful. So now your answer will change from observation to mammogram by my little aggressive explanation. Fair enough.
Yeah, yeah.
But
Fair
sir,
enough. Any
age
other
is
comments in the house?
35. Age is
Actually, the
35 to
best answer
mammogram
is
is not
ultrasound,
indicated.
but it is not there option.
No, we have to select from A, B, C, D, E only. That's it.
Sir, age is 35 to mammogram is not good for her because she is in reproductive age.
Okay. So if we do the mammogram, what harms to the patient at for 35 years of age? Say
It's
somebody has done the
premature
mammogram
ovarian
for this
failure.
patient.
Rays will cause premature ovarian failure
How come by giving doing the
No, this
mammogram, doing the premature ovarian failure? What is the mechanism?
because
no,
highly rays, ultraviolet rays of the
because
mammogram.
in the young
Radiation.
woman, the dense breast tissue will be
Yeah.
dense, so it is not advisable.
Breast tissues are
Uh,
dense, so
Yes,
mammogram will
doctor.
be very
Doctor,
painful and difficult.
fair enough. So it's at any age, not very painful. Let me tell you, it's a little painful, not very painful. So, Dr. Nisa, you also answered the things. What do you think? What could be the best, most appropriate thing with the explanation? Yes, Dr. Jay Rawal. Is there any explanation, sir, for you why you selected mammogram? Dr. Jaya, am I audible to you?
Yes, sir. Yes, sir.
Yeah, you can
Sir,
answer, sir.
because
Don't worry. This is
yes, sir.
a learning platform. Don't worry, right or wrong. Just answer something. Yes,
Sir, because I thought mammogram will be helpful to diagnose.
wonderful. So, what you want to diagnose in this by doing the mammogram? What information you want to get, right? Okay, fine. This lady
Mhm.
comes to you tomorrow morning. You did a
Yes, sir.
mammogram. So, what you are looking for in mammogram? Why you want to do mammogram?
Uh, Let me think about it, sir.
To look for any early stage cancers.
Sorry.
To detect, sir, any early age cancers like
No,
Wonderful.
first you go brush half. You don't take now. Go.
Hmm.
You mean go to
Anybody?
washroom first. Go. Where are you going to
Getting you, doctor, your answer. A lot of background
go to
children
washroom.
noise.
Go to washroom first.
Please mute mic.
Fair enough, no problem. So now let me go. Any other comments? Anything? I mean, it's a very important and very, very common questions in the clinic. Young female coming with the breast lump, what to do with this patient, right? So absolutely. Why, Dr. Mifra, you want to do the follow-up for the next cycle? What happens or what things will going to happen in next cycle?
So as she complained of tenderness, I was thinking maybe it's a cyclical pain.
No,
But
it is not
now I
mentioned that
feel I
every
will go with biopsy
every
also.
menstrual cycle, they have not mentioned that every period she has a
No,
pain,
sir.
she has a
Now I will
tenderness in
change the
breast.
answer to
They have not
biopsy,
mentioned.
sir.
And something is not mentioned means it is not there. You hear vitals is not mentioned. What is the vitals of this patient? Not mentioned means stable. You got it. This is exam tips and tricks. Something not mentioned means normal. Right. Anybody wants
So
to
I will
give the
go with
comment on this?
biopsy, sir.
Fine. Biopsy is bit aggressive. What don't you think this is bit aggressive in patient?
Yeah.
Right? Because
Next
you don't
is
know no, it is cancer or not. 35 is not usually age for cancer. Usually we see and in India, especially in our practice, right? Usually we see after 40, 45s or higher the age increases the risk of cancer. But in general, very less. I mean, less than 30 is absolutely very less. Less than 40, small percentage, more than 40, more percentage of getting cancer of breast or any other cancer. So age itself is the biggest risk factor for developing cancer. So what are the risk factor of cancer? One of the biggest risk factor is age. Yeah. So let's discuss and we'll discuss a lot because this is so common questions. Every day you will see such patients if you are in oncology OPD, right? Lots of female 20 years, 25, 30 years coming up with, sir, I have breast lump. I'm worried about cancer. What to do? Right? Then you have to do it. So let's go scientifically evidence-based medicine. If somebody does not agree, we will discuss after my explanation. So correct answer is mammogram. Listen me carefully, then we'll discuss. Clue in this question, age is 35, symptoms breast tenderness and diffuse nodularity. Everything from scenario only, huh? Just to make you remind. So first I am dissecting the question. What is the clue in this question? Age 35, symptoms breast tenderness, diffuse nodularity, palpable mass. You can see here the palpable mass, everything is written here, 3 centimeter palpable mass, everything is there. So palpable mass, 3 centimeter mobile mass. This finding suggests likely fibrocystic breast changes, but because of the age is more than or equal to 35 with a palpable breast mass, the first investigation is the imaging, and that is with the mammography. Age based investigation rule for the breast lump, which is high yield for exam, less than 30 years of age, any female comes to you with the same thing, better you go for the ultrasound. More than 35 or equal, go for mammogram. And suspicious lesion on mammo or sonogram, you need to do first biopsy. Why? Because it is highly sensitive and specific. We'll see head to head comparison between FNAC and biopsy. Very frequently asked questions. So biopsy or FNAC. If biopsy is not available, you can go for FNAC. But if somebody asks you what is the first, if the biopsy and FNAC in option, what is the best to select is biopsy. Reason, high sensitivity specificity. Number two, you can do the ER, and HER2 on the biopsy, not on the FNAC. It's a liquid sample, so you cannot perform, right? FNAC, high chance of false negative. In spite of having a cancer, you may miss in FNAC, which is extremely rare in biopsy. So these are the pros and cons of biopsy FNAC. Why other options are incorrect, right? So first we understood that okay, mammogram is perfect. Now why other options are not there? That is our equal job, and everybody has to do same exercise every day in every MCQ. Your job is not just to get the diagnosis, but you have to rule out all four. Why not FNA? Why not biopsy? Why not follow up? Why not observation? So let's go deep dive into this option. FNA with cytology done after imaging if lesion is suspicious. If mammogram is absolutely normal, in that case,
हसीबा
you may
दरवाजा खोलो
probably.
ड्रेसेस चेक करना है बेटा
Dr. Safa, can you close your mic? Dr. Safa, close your mic, please. Okay, let me mute all. I muted all. If somebody wants to interact with me, you can unmute. You have facility down there. Right? So FNA with cytology done after imaging lesion is suspicious. Biopsy, not first step. Without imaging, you don't know whether it is benign and malignant. Why you want to do something invasive procedure to the patient by entering the needle or doing the biopsy? So just get the idea, right? If you are suspecting lung cancer, just get the imaging, CT scan, PET scan, then do the biopsy, right? Likewise, right? So do some radiology and then tissue diagnosis. Once it is suspicious, follow-up of the next axle acceptable for mild cyclic pain, which is not mentioned here, without a discrete mass, without a discrete mass, without a discrete mass. We have 3 centimeter of mass. So if there is a no mass, right, it's a mild cyclic pain, classical menstrual pain, observe it, follow it. That's it. Observation, a 3 centimeter mass required imaging evaluation for sure. 3 centimeter is like T2. If you go the classification of breast cancer, up to 2 centimeter T1, T2 is 2 to 5, T3 5 centimeter plus, and T4 either skin PUD orange or chest wall involvement is T4. So this comes in T2. So it's not small tumor. So you need some kind of evaluation for this patient, and observation at all is not suffice for this patient. So concluding our talk, the clinical exam tips are there: breast tenderness, diffuse nodularity, often fibrocystic changes, but any palpable mass in more than 35 years of female must go for the mammogram first, and then decide, depends the availability, that what you want to do, FNAC versus biopsy. Biopsy would be best, then FNAC. And this is the general understanding of all the things, how the FNAC and biopsies and all will change one to one, right? So FNAC is a fine needle aspiration cytology. Sample here you collect only cells, right? Not the tissue, only cell, right? The name itself, fine needle aspiration cytology, few cells you collect. Architecture you cannot see. That is why it's not a sensitive test than biopsy. Here the architecture is very well you see, right? Normal cell, abnormal cell, because you got a good core needle biopsy. Here you get only cell, so there are chances of missing the cancer cell in FNAC. That is why it is a less sensitive and specific test compared with the core needle biopsy. Invasion detection cannot be possible. You cannot perform ERPR and HER2, because this is one of the two major treatment for breast cancer patients. If ERPR positive, estrogen progesterone receptor, you need to give hormonal therapy. If HER2 is positive, you need to give trastuzumab, right? So these are the two major, and three other treatments: surgery, chemotherapy, radiotherapy, and these two other treatment. Total 5 treatment for breast cancer: surgery, chemo, radio, hormonal targeted. That is HER2 targeted, her trastuzumab. I'll teach you right now in next 2 minutes. Invasion minimal, you cannot see. Accuracy is little mild to moderate. Accuracy is mild to moderate. Core needle biopsy, absolutely. This is the test globally people do world over. Core needle biopsy will do for any breast mass which is palpable, whether fixed or movable. True core needle biopsy. Why? You can see the architecture. Invasion, you can see. ERP or HER2, you can perform. Invasiveness, you can do. Sensitivity, accuracy, high. This all advantage. Why we gonna do the biopsy, not the FNAC? Where the FN biopsy is not possible. Somebody is living in very, very remote area in the village where nothing is there in 100 kilometers. In that case, you do the FNAC. If somebody is comfortable, you do FNAC. But if you have choice between this and this is the best. Excisional biopsy, almost the same advantage like core biopsy. Only disadvantage, it is kind of surgery. It's a surgery. So it is very difficult, right, to remove the whole lump, getting into the operation theater. And whatever the information you are going to get with the core needle biopsy, same information will you get with the excisional biopsy. So in practice, for last many years, we perform this only, and it's absolutely sensitive and specific, and you can get all the informations what you want to get it for these things. So considering FNA, core needle, and excisional biopsy, best is core needle biopsy, right? It can be done as a OPD, outpatients department, right? It's just 5 minutes job. You need to give little local anesthesia to the breast lump, take a needle and gun. There is a gun which you have to shoot the gun in the lump. They will take a very small tissue, right? You can see under microscope in next 2 days there is a answer whether cancer or no cancer. So what is the final trick? I mean, the take home message for this is, right, for our cases, FNAC where you see the cell only, right? So, and core biopsy, tissue biopsy, gold standard, right? And excisional biopsy where remove whole the lump which is not required, right? You get the same thing. Cancer is there or not by core biopsy or by excisional, but excisional biopsy is a bit more aggressive, more painful, may need hospitalization, and increases the cost. Core biopsy, absolutely 10-minute procedure, outpatient, you just biopsy do and send them home. That's it, right? So suspected breast cancer diagnosis should be confirmed by the core needle biopsy, not at all by FNAC, if you have options and choice, right? So that's it. And this is what the advantage I already told you, right? FNAC has advantage and disadvantage. So what are the advantage? FNAC is easy, it's relatively painless, office-based procedure, very small needle, What are the disadvantages? Requires expert cytopathologist, unable to evaluate histopathology, unable to do ERP or HER2, right? And sensitivity and specificity is much lesser than biopsy. That is why this is a second option, not a first option. First option is core needle biopsy. Advantage, it is also easy, relatively painless, office-based procedure, standard histopathology, able to access tissue architecture, and there is a less chance of false negativity, and able to obtain the receptor status like ERP or HER2, which is not possible in FNA. So, considering all the pros and cons, biopsy is absolutely unbiased based investigation of choice. Once you have high suspicious by imaging, by sonography, by mammogram, or in very young age, MRI also can be done because of dense breast, right? So, if some female comes less than 30, USG, you cannot find anything. What to do? If you are still thinking of cancer, go for MRI breast, right? So this is what the international guideline is. So that's all from my side. I will switch to the next questions. Before this
Sir,
next questions, if anybody has any questions, we can
sir,
discuss now for next 2 minutes.
sir, here is the right answer is A here in this slide.
Sorry, sir, I'm not getting your question, sir. Can you please repeat
Sir,
your question?
sir, in this slide, correct answer is A.
Which slide? This slide?
Yeah, no, sir. Next, last one. The here, sir, here is B option,
No,
and
no,
in this, this.
the wrongly mentioned. It's a, it's not A, sir. It's a mammogram.
Uh, ठीक है सर और another sir if there is another option core biopsy here option G so there will be answer will be core biopsy.
Not confuse you, sir. They will not confuse you. Let me tell you, in the exam, the options are absolutely clear cut. There are never a two answer, right? We got confused ourselves in the exam, right? Likewise, we are confusing ourselves. Why this not, right? So there is an absolute clear cut question in the exam. So if your concepts are clear, you can easily answer. Dr. Jay, are you getting me what I'm trying to explain? Jay, Rawal.
Yes, sir. I can get. Yes, sir.
Right, so try to go read, open up the books and again study. This is
Yes.
absolutely high yield. We discuss lots of question in one question, right? So where to do, what to do, now patient comes to you, how you supposed to investigate, so you just keep in mind, right? So let's jump to the next question. A 68-year-old, that is 35, now this is 68. 68-year-old woman visits her physician with solid peanut shaped hard mass in upper outer quadrant of left breast. A biopsy of the lesion reveals infiltrative or invasive, both are the same thing for your kind knowledge. So, infiltrating ductal carcinoma or IDC. What is the next step in the management? Right. So, they had given, before I jump to this next, this thing, let me tell you, just fix in your head. This is one of the most high, highly, what I can say, effective way of this doing. I always ask three questions to myself. What is the diagnosis of this scenario? How you supposed to investigate? And what is the treatment? Any exam in the world, they ask these three questions. USMLE, PLAB, AMC, Canadian board, Irish board, PROMETRIC. Either they ask you diagnosis in MCQ, either they ask you investigation, either they ask you the treatment. So now onwards, what you want to do for your patients, or every MCQ asks three questions. So in this question, we will answer these three things, right? So what is the scenario? Once again, 68-year-old woman visit to her physician with solid peanut shaped hard mass in upper outer quadrant of left breast. They did a biopsy, and biopsy showing IDC, means it's a carcinoma, means cancer. The layman is cancer, medical is carcinoma. So our diagnosis is done. Number one job is done, sir. We have a CA breast or carcinoma of breast. This is done. They investigated already. How did they investigate it? They did a biopsy. They mention here they did a biopsy. So by biopsy, by investigation, they make things that okay, we did a biopsy, it's invasive ductal carcinoma, it's a breast cancer. Now what's the management? What is they are asking? Management, treatment, what they are asking. So what will you do now? Lumpectomy with lymph node sampling plus radiotherapy, modified radical mastectomy, modified radical mastectomy plus radiotherapy, neoadjuvant chemotherapy plus lumpectomy plus radiotherapy, or you gonna give tamoxifen and radiotherapy for this patient. So you take your own time. You take your own time. You don't need to be panic. You don't need to be panic. You just think over it what you want to do, and we'll discuss why. Will our job is to discuss why not this. We need to rule out A, B, C, D, E. So now you post your answer in the chat box. Then I can pick up one volunteer to discuss this question. Yes, post your answer. Post something. Think that if this question comes in your FMG, your NEET PG, or your DHA, or USMLE, or MRCGP, if you are preparing and this question comes, how you supposed to respond? You have to answer at least one thing. If you don't answer, means you are gone. 0 marks. We don't need zero. At least answer wrong thing. If by chance it is correct, then it is happy. No? We are happy. Yes, Dr. Safa, I would like to understand from you why you selected the C. Uh, you convince me modified radical mastectomy plus radiotherapy. Why we want to give to this patient? Why you don't want to select A, B, D, and E? Why you selected C? Yes, Dr. Safa Aisha, if you can able to answer this, I would be happy.
Sir, because it is a ductal carcinoma.
Okay, great. It is ductal carcinoma. They have mentioned it. Yes.
Yes. So we do a modified radical mastectomy. Whenever we do a modified radical mastectomy, it should always be accompanied with radiotherapy.
Wonderful. So this is absolutely a wrong concept. I'll explain you. Not just the wrong concept. I'll explain you. So why you want to give the radiotherapy to this patient when he has a very small solid peanut? Peanut is less than 2 centimeter, very small early disease, right? You can't avoid radiation in this. And why you want to remove the whole breast? You can't do the breast conservative surgery. The difference between MRM and breast conservative surgery. This is the breast picture. This is nipple. Say for example, this is a small peanut shaped tumor. In breast conservative surgery, what they will do? They just remove the breast lump. They just remove the breast lump and they do the axillary dissection. This is called breast conservative, where you did not remove all the breast. You did a wide excision, local lumpectomy with a wide excision and remove. What is MRM? Right? So they have on the right, where is the left breast? So this considered this is left breast. This is the problem. This is right breast. In MRM, breast, this is completely chest wall. This is post surgery chest wall. There is no breast tissue at all. Complete 100% breast is removed. So what you have is just the chest wall, and here the right side normal chest. So why don't you want you to save the breast? I mean, you cannot save the breast when the lump is small. You don't want to, because it's a psychological trauma. When I counsel my patient, you need to go for surgery and we'll do MRM, modified radical, will remove whole breast and axilla. They are not happy. It's a natural organ God has given to the female. They wants to preserve if possible, right? So it is not always the MRM is the answer. Not always the MRM. There are indication of MRM. There are indication of breast conservative surgery. So I'll tell you all indication. It is very important, and you must give the option to the patient. So this is what just discussing point with you. I want to go for lumpectomy. I don't want to remove the breast. I want to go for this. Now you convince me why you want to do MRM. The convincing point for me, tumor is small because it's a peanut shaped small tumor, right? Right? And that's it. It is not spreaded anywhere else, right? They have not mentioned means normal. So very small tumor in an elderly female. I'll just remove and I'll go for radiotherapy. I don't want to remove the whole breast. Now you tell me, or anybody can tell me or discuss. It's open for all.
For small size tumors, you usually don't do modified radical mastectomy. You try to conserve the
Wonderful.
breast.
Wonderful. So that is the biggest advantage of doing the breast conservative surgery is early presentation. If you go and read up the breast cancer chapter, there is early breast cancer, there is advanced or late breast cancer. Stage 1 and 2 is early breast cancer where the tumor size is normal, and it is not spreaded to the axilla. That is early breast cancer. And whenever there is early breast cancer, the goal is to preserve the breast, right? And let me tell you the result of MRM, means modified radical mastectomy versus breast conservative surgery is the same. The only thing we'll add in breast conservative therapy is radiation is 100% mandatory to reduce, because you are not removing the whole breast, just lump and axillary dissection. So there is an increased risk of local relapse. And to reduce the risk of local relapse, global guideline is when there is a breast conservative surgery, radiotherapy is mandatory. So this is the answer: lumpectomy with lymph node dissection or axillary dissection plus radiotherapy. Why radiotherapy? Because you did a lumpectomy. This is guideline, global guideline, right? So it is not mandatory to go for modified radical mastectomy with radiotherapy. Dr. Aisha, any comment? Safa Aisha. Anyone wants to have any comment on this?
Sir, it means it depends upon the size of the lump
Yes,
in whole
absolutely. No? Absolutely. When some female comes to you with 1 centimeter, 1 centimeter is very, very small lump. Why you want to do MRM? Why you
Yeah,
want to
you
do
are right.
MRM? Right? This is the breast and there is only 1 centimeter, right? So you remove this part. Na? Why you are removing the whole breast, and after cure, whole life female is in psychological trauma. I have no breast, I have no breast, I have no breast. It's a psychological issue. You probably see it when you counsel the patient after MRM, after cure of breast cancer. Many female comes to me, sir, what to do now? Breast. Will implant. We do the silicone implants, right? Or we do the prosthesis of the breast, but again it's not a natural, you understand, right? So whenever you want, I mean, if feasible, try to preserve the breast of the female. Where you cannot do
Insert?
the where, 1 minute, let me finish, then you ask. Where you cannot do the breast conservative surgery, where you cannot do breast conservative, when there is a large tumor, very large tumor, like whole breast is covered with tumor, where it is not possible. Second, multicentric tumor. This is breast. One tumor is here, one tumor is here, one tumor is here, one tumor is here, one tumor is here. It is multicentric, where breast conservative, because you cannot do here, here, here all surgery. You have to remove all. Multicentric tumor. When there is a T4 disease, PUD orange, skin involvement, chest wall involvement, multiple lymph nodes present in the axilla, which is a high risk disease, where you try to avoid the breast conservative. So breast conservative usually do in early disease or less than T1, right? And another is in young female with the cosmetic things. Say for example, Hollywood star, she has a breast cancer and age is 30. How feasible to tell her that okay, remove whole breast? Do you think she will agree? Do you think she will agree? Not agree. Not agree. 100% not agree. Her job is something like exposed to the people, right? On the movie, right? So she can't afford to lose the breast conservative surgery. So as far as possible, try to evaluate if you can save the breast. That is called breast conservative surgery. If not possible, then you go for MRM. But the first, always never ever think of MRM in all the patients. You have to justify, right, to the patient that okay, she deserves MRM, she deserves breast conservative surgery. So here the answer is right. So this is a 68 years old woman, hard mass upper outer quadrant, invasive ductal carcinoma. It is one of the most common cancers. Somebody asks you second question in exam, which is the most commonest histology in breast cancer? Invasive ductal carcinoma. Another is invasive lobular carcinoma. So lobular is not common, ductal is common, right? So let me tell you one more second I will spend for you guys. So this is a breast, this is a nipple, right? So all milk forming ducts are coming, and there is a lobule. If you go and look at the anatomy, if it is developed in lobule, it is invasive lobular carcinoma. It is developed in the duct, invasive ductal carcinoma. Just for your knowledge. If they ask you in exam, which is the most common histology? Invasive ductal carcinoma. Which is second most? Invasive lobular carcinoma. Second question in exam, which histology usually present with the bilateral breast cancer? Answer is invasive lobular carcinoma usually present with the bilateral, right breast cancer, left breast cancer, which is a common histology, lobular, not invasive ductal, just exam point of view. So this is one of the most common cancer. If the tumor is localized and operable, standard treatment is breast conservative treatment or surgery, shortly globally known as BCS, breast conservative surgery. Breast conservative surgery consists with lumpectomy. As I told you, this is a breast, this is nipple, this is a tumor. So they remove the lump. That is why lumpectomy. Lymph node sampling. From axilla, they remove the lymph node. So it is a lymph node sampling. And once you did this conservative surgery, adjuvant radiotherapy is 100% mandatory. These are the key points. Radiotherapy is required after lumpectomy. Why you want to give radiotherapy? Already told you, to reduce the risk of local recurrence, right? And now let's see why not other options? Why not other options? That is also important. As I told you, right? Our job is not just to get the answer A, B, C, D, E. We need to rule out all other options. Why not? Right? B. Why not B? As many people told, sir, I want to do lumpectomy, MRM. Usually used when tumor is large. Our is not large, our is small. How did we get to know our is small? It is peanut shaped. They already mentioned peanut is like around less than 2 centimeter. So MRM for large, our is small. I'm giving you head to head comparison. When there is a multicentric, I told you already, in one breast there are five. This is five places there is a tumor, right? It is multicentric. One center, only one. This is only one, unicentric. Multicentric means all quadrant. There are four quadrant: upper outer, lower outer, upper inner, lower inner. And this is breast and axillary tail. Go and read the anatomy. So multicentric in all four lobes of the breast, it is not good idea to go for breast conservative. Do MRM. So large multicentric or breast conservation is not possible, then you think of MRM. Here we can think of, because our tumor is small, there is nothing else, we can go for breast conservative surgery. Modified radical mastectomy plus radiotherapy usually for advanced disease. Our is not advanced disease. Positive margin, our is negative margin. Large tumor, our is small tumor. So this is also not the answer. This is also not the answer. Neoadjuvant, absolutely wrong answer, because neoadjuvant usually do for locally advanced. Our tumor is not locally advanced. Our tumor is only localized small tumor, right? So this is, and tamoxifen and radiotherapy is not answer. Hormone therapy alone is not primary treatment for operable breast cancer. So whenever there is a operable things, you must operate the things. So surgery is number one treatment, especially in early disease. So somebody is asking, sir, what to do in a late disease? In late disease, you give NSAT, means neoadjuvant chemotherapy, reduce the tumor size and do the surgery. That's it. This is the guideline international. So this is not the answer. So what is the correct answer? A lumpectomy because of small tumor, right? And lymph node sampling. When you do breast conservative, radiotherapy is 100% must. So this is final answer. Early stage invasive ductal carcinoma, do the breast conservative surgery and radiotherapy. That's all from my side. It's now open for discussion, right? So there are 5 treatments globally available for breast cancer, which I am counseling every day to my OPD to the patient, right? Number one is what is the number one is the surgery, right? So surgery, why, when to do surgery? When disease is operable, or what do you mean by, sir, operable disease? Early disease, T1 or T2 disease, no nodal involvement in axilla, right? Small size of tumor, which is early disease, peanut shaped, breast conservative. So preferably breast conservative. If cannot be done or offered because of any indication like multicentric disease, go for MRM. So in surgery, you have to counsel whether BCS is possible or not. If not, then breast conservative. There is no other surgery offered globally. Once you do the surgery, after 3 to 4 weeks, you need to start a chemotherapy. What are the criteria for chemotherapy? That is also a question. Sir, I am always confused when to give chemo, when not to give. So this is simple one line answer. Node is positive. So when the node is positive or tumor is more than 2 centimeter or high risk biology, what do you mean by, sir, high risk biology? HER2 positive, ERPR HER2, that is called negative, that is what we call in our practice is TNBC, triple negative breast cancer. What do you mean by triple negative? ER, PR, and HER2. These three things is called triple. If all three negative, it is called triple negative. If all three positive, it is called triple positive. So triple negative breast cancer is a high risk patient where you have to give and offer chemotherapy, right? Can be neoadjuvant. What do you mean by neoadjuvant? Before surgery. So if you give chemotherapy before surgery, before surgery, it is called neoadjuvant. And once you do the surgery and then chemotherapy, it is called adjuvant. So before surgery chemo, it is called neoadjuvant chemotherapy, shortly NACT, and here adjuvant chemotherapy after surgery. So these are the two terms, neoadjuvant, adjuvant, depends on the stage class you can give it. Third treatment, radiotherapy. Who deserves radiotherapy in breast cancer? 100% after breast conservative surgery or high risk mastectomy or MRM. What is the advantage? It reduces the risk of local, not systemic recurrence. Local. Fourth treatment is targeted therapy. What do you mean by sir targeted therapy? So HER2 is receptor. So this is a breast cancer cell. On that, there are three receptors science in right invented. One is ER, another is PR, third is HER2, right? So whatever present you can block and you can reduces the growth or do the apoptosis or death of the cancer cell. So if ER positive, right, or PR positive, give hormonal treatment because these are hormone, estrogen hormone, progesterone hormone. That is why they are telling hormonal treatment, right? So either of these or not both the things positive. ER positive, PR positive, or let me tell you one more thing which is not written. ER and PR positive. Anything is there, both positive, you give the hormonal therapy. Likewise, the HER2 is not the hormone. That is why it is not name is hormone. It is one target which is situated in the breast cancer cell. This trastuzumab just kill the cancer cell which carries HER2. So it is that is why it is called targeted therapy. This is targeted therapy. Target. You target specific thing. And this targeted therapy opens the major way in our treatment. There are hundreds of targeted therapies available, right? I'll few name HER2 positive in breast cancer. We give trastuzumab. Few example I'll give you just for your clarity. EGFR positive in lung cancer, we give gefitinib. Now, the name of the drug is gefitinib. In CML, we find BCR able, we give imatinib or give, right? CML, we give the imatinib, right? So likewise, there are lots of targets available now, right, for various cancers. So you need to find out that target. There is a drug available for this, and you can cure or you can improve the overall survival of the patients by adding this drug. So this is an international small slide. You can take a picture. I would be happy and glad, right? So you can help your patients. Right, so these are the five treatments: surgery, chemo, radio, target, hormonal, when to give, when not to give. I told you, so just keep in mind. That's all from my side for these questions. Any queries, concerns, questions, I would be glad and happy to answer. 1 minute I'll spend for your queries. Is everyone clear? At least
Adjuvant,
tell me yes or no. At least tell me yes or no.
sir, little question, sir. What is the difference between the adjuvant and non-adjuvant?
Sorry, what is different between adjuvant and non-adjuvant? Adjuvant is
Yes.
basically, yeah, so one is adjuvant treatment, right? Adjuvant is once you do the surgery, say for example, breast conservative surgery, you did it, and after that you are giving the chemotherapy to this patient. It is called adjuvant, post-surgery chemotherapy. What is neoadjuvant chemotherapy? First you give the chemotherapy and you do the surgery. Then have another question which you did not ask me. Sir, why we want to give the neoadjuvant? Why you are not doing adjuvant for everyone? So when the tumor is large, when the disease is advanced, right? In that case, say for example, tumor is this much in the breast. This is breast, big, huge tumor. After giving chemotherapy, right? After giving the chemotherapy, we reduce the tumor size. Then we operate. So give 6 to 8 cycle of chemo, make the tumor size from 10 centimeter to 2 centimeter, which makes more feasible. two advantage. One, you can reduce the tumor size, you can know the response of the treatment, and this chemotherapy will not take care of the local disease, but it also take care of the systemic disease like liver, lung, bone, brain, if it is metastatic, right? So usually in early or advanced stage, so shortly I can tell you stage 1 and 2, surgery, then chemotherapy. That is called adjuvant. Stage 3 and 4, first chemotherapy, neoadjuvant, then surgery. Just for simple understanding. Is that clear? I think you got your answer. Are you getting me? Yes or no?
Yes, sir. Yes, sir.
Any question?
Sir, I just wanted to ask, like
Yes.
after neoadjuvant, after we do surgery, do we give anything like radiotherapy or chemotherapy?
Yes,
Like
sir.
after
Yes, sir.
surgery?
Yes, sir. Let me, good question. So say for
Mm.
example, tumor size is 8 centimeter, right? So it's a big size. Anything more than 2 centimeter is big, and absolutely 5 centimeter is very big. So this patient has 8 centimeters. So had given the neoadjuvant chemotherapy, right? Probably
Okay.
we have given 8 cycles, say for example. Now tumor from 8 centimeter now become 2 centimeter. Now
Yes, sir.
it's easy to operate as well. So we had given the surgery as well. So we
Okay.
did the NACT, we did surgery. What to do with this three treatment, whether to given or not, right? So
Mm,
so
that's
when
the
there
question.
is a 8 centimeter tumor at baseline,
Mm.
radiotherapy is 100% mandatory. What are the
Oh,
indication of radiotherapy? Tumor is more than 5 centimeter, give radiotherapy. Breast conservative surgery, give radiotherapy. Axillary lymph nodes positive, give radiotherapy. So this patient has 8 centimeters, so she deserves radiotherapy. Are you getting me?
yes, sir.
And we need to look for three receptor, ERPR and HER2. If
Mm.
ERPR is positive, we'll give the hormonal therapy tamoxifen or letrozole for 5 years. And if the HER2 is positive, we give the trastuzumab for the 1 year. So this is a final plan for this patient. If the HER2 is negative, will not give it. If hormone ERPR negative, will not give it. So treatment would be chemo, surgery, radio, observation for 5 years. Is that clear? Yes or no?
Yes, sir.
Any confusion?
Yes. Thanks a lot.
Wonderful. So we need to look at the all three receptor, which is not possible in FNSE, ERP or HER2. Why it is mandatory? Because it carries two treatment. One is hormonal treatment, right? And another is targeted therapy. So ERP or HER2 is 100% mandatory, whether it is stage 1, 2, 3, 4, 5, whatever. Once the breast cancer diagnosed, ERP or HER2 is mandatory, which is not possible from FNSE. That is why day one, we do the biopsy, core needle biopsy, sent for histopath and ERPR in a one meeting, in one sitting, to just avoid the time wastage, right? Otherwise, what happen? Oh, invasive ductal carcinoma. Now you go for ERP or HER2. Don't do that. I write down in my prescription. Okay, in first visit, do the biopsy, send ERP or HER2. Within 3 days, everything come up. I'll start treatment. Is that clear? Yes or no? Jay, you got the idea? Did you get the answer of your question, or still there is confusion?
No, no, sir. I got it. Thanks a lot.
Wonderful, brilliant. You are a very clever boy.
Thank you,
Wonderful.
sir.
Wonderful. Any other questions, or I'll move to the next question?
Hello, sir.
Anybody has any doubt, anything in
Yeah.
your
Hello,
mind
sir.
for
I
breast
have
cancer?
question.
It's a golden opportunity to ask. Ask me, sir, please.
Hello, sir. Hello, sir.
Yes, sir. Ask me. Sudesh, sir, please ask.
Hello. Yeah. Yeah. Sir, after neoadjuvant chemotherapy, is surgery best conservative surgery or mastectomy, sir?
Sorry,
If,
can you
if the
speak bit
tumor is
louder and
large,
clear? I can't get your questions well. Yes, please. What's
uh,
the question?
if the tumor is large, we go with neoadjuvant chemotherapy first. So
Okay.
after giving chemotherapy, the surgery, is it best conservative surgery and radiotherapy or radical
Usually,
mastectomy?
yeah, it's a good question. So after neoadjuvant, what to do? Breast conservative or the MRM? Usually, when give the neoadjuvant chemotherapy means it's an advanced disease, stage 3 or 4. So most of the patient opt for the MRM. When we counsel the patient, that in advanced disease, say for example, stage 3 disease, you give neoadjuvant chemotherapy, now surgery, what to do? Breast conservative or MRM? Because in neoadjuvant chemotherapy, when tumor is large, nodes are positive, high risk disease, then and then we give the neoadjuvant chemotherapy as per our literature. So in that case, usually we prefer MRM in case of especially neoadjuvant cases, right? Are you
Thank you,
getting me? Yes or
sir.
no?
Thank you, sir.
Right? Because
Yes.
neoadjuvant when we give when there is a high risk patient, high risk disease, in that case we usually give neoadjuvant chemotherapy. Otherwise, small tumor we operate and then give chemotherapy, right? So usually the answer, best appropriate answer is MRM. Great, wonderful. So I think a lot of discussion. Those who have something right more to ask me, just drop me the message on my WhatsApp. So we'll guide you more, right? So now third question. Then we'll switch to hematology as well. Don't worry. This is like important things, and 90% of the doctor get confused between these all terms, right? FNAC, biopsy, open biopsy, excisional biopsy, true cut biopsy, mammogram. That is why I included this. One liner questions, but very important. I want the answer perfectly. Which of the following screening test lowers the mortality the most? Mammogram above 50, mammogram above 40, colonoscopy, pap smear, or some other test you want to mention here, like stool for occult blood or PSA or any other test you want to mention, you can mention. This is the list. E is a PSA and F is stool for occult blood. Just for your knowledge. Okay, fine. So you have 6 options now, or at least first 4 options. What you want to select and why? I will ask only why. I'm interested in why. A, you tell me why. B, why. C, why. D, why. Whatever answer, it's why. Yes, let me check the chat box. How many have actively participated and answered? Yes, Dr. Sudesh. So I think you are telling a mammogram above age of 40. So now tell me why you want to do mammogram 40. Why not 50 then? My question.
Yeah. Sir, mammography detect breast cancers early in sometimes before it is palpable, and CA breast has very high mortality if it is advanced, and it when it is cause metastasis increase mortality. So I thought of doing mammography after 40
Okay, fine.
gives the highest, yeah,
So
low
how much
mortality most.
in terms of percentage, if you do mammogram after 40 years, how much percentage of mortality means death? Simple word of mortality means death. So how much death you can reduce if you start after 40? How much you can reduce the percentage of death in female if you do after 50? What do you think? Anybody has any answer? Like 10%, 20%, 50%? How much mortality we can reduce by doing the mammogram after 40 and after 50? Any breast expert in the house? Yes, Jay, what's your answer, Jay?
Around 40%.
Around 40%. So it's a big number. Fair enough. Let's see. I'll see you with the literature. I will not just tell you. I'll give you with the facts and figures and international guideline in next couple of slides. Yes, Jay, what you want to do for this patient if this
So
question
like
comes
if
in
we start
NGO?
early, that's good, right? Like if we start early on
So
40 years, then it will be
when
more helpful. Less
okay.
cases of mortality. That's why age 40 like B option.
So why Jay you did not selected the pap smear? Pap
XPR.
smear does not reduce the mortality because
Yes, sir.
pap
Yes,
smear can detect
it
pap
does.
smear can detect the precancerous stage. Even not
Yes.
cancer.
Yes.
In pre-cancer, you can detect by the cervical cancer. While in
Okay.
mammogram, you cannot detect in a precancerous stage. You can detect in early stage, not in the precancerous stage. You can detect in mammogram. So why you did not selected pap smear? Why you did not
Mm.
selected colonoscopy? Just for my knowledge, I'm just trying to understand what's your concept. Are you okay, Jay?
Yeah, yeah, sir. Uh, I'm thinking, sir.
No problem. It's important point, isn't it? It's important
Yes,
point, na?
sir. Yes,
Clinically
yes.
important. Why you don't want to do? Because pap smear can detect in a preclinical stage or pre-cancerous stage, and mammogram only just detect in a cancerous stage. Yes,
Mm-hmm.
anybody, any expert of pap smear, cervical cancer, female gynecologist in house, they can better answer this.
Pap smear, you have to go for the liquid-based cytology also.
Fine, fine. So what I will give you the liberty to select, reselect the answer. What you want to select now? Mammogram is not the answer. Forget mammogram now. So you
Sir, I
see,
think it's
Answer is
sir,
pap
I think
smear,
it's
sir.
colposcopy at the age of 50 and pap smear both should be the answer. There should be
yes,
their
col
option all in.
so wonderful, brilliant, Dr. Rabia. So colposcopy is not in the option. Then what you want to do? This is the question in
Pap
DHA. What you
smear.
want to?
Then pap smear.
Wonderful.
Because
Then pap smear.
mammograph, yes. Because CA breast
Wonderful.
mortality is not too much high as compared to CA colon and CA cervix.
Wonderful, brilliant. So now let's jump to the literature now. All right. So answer is a pap smear. If you
Mm-hmm.
listen me well, 99% doubt will be cleared. This is all evidence-based medicine. Among the options, the pap smear screening for cervical cancer has produced the greatest reduction in the cancer mortality or death in a population screening program. Pap smear used for cervical cancer screening detects the precancerous lesion CIN1, CIN2, CIN3, carcinoma in situ, and invasive. We have brilliant question in the next slide. So detect precancerous. Mammogram cannot detect precancerous. It can detect the early cancer, not the precancer. So there is a difference between precancer and cancer. Are you getting me? Yes or no? So it
Yes,
can
sir.
detect the precancerous lesion like CIN stands for cervical intraepithelial neoplasia before they became invasive cancer. I will show you in the next slide. Country with organized screening program: Australia, Sweden, Norway, and UK. Almost they are by 2030 or 2040. Absolutely, there is a zero case. This is the projection of the Western world. By next 10 years, they have not a single case of cervical cancer in the whole country because of three things. One is awareness, second is vaccine, third is pap smear and early detection. That's it. This is the key to success in this country, which is not usually happen in Asian countries like India, Pakistan, Nepal, Bangladesh, and few Middle East, where the screening program is not there mandatorily. So I'm 100% sure in this meeting there are 50% female. Ask yourself how many times you did HPV DNA test, how many time you did your pap smear. Most of the answer is no. I don't want to disclose the name. You ask yourself. If not, go and do it. If not, go and do it. Right. So country with this, right? These are the country. Mammogram more than 40 or 50 reduce the breast cancer mortality 20 to 30%. Right? How much? 20 to 30%. So 20 to 30% of the death reduced by doing the mammo after 40 or 50. 80% of the death is reduced almost 2 to 3 times. Right. So that is why pap smear reduces the mortality more. I am driving the cervical cancer drive. I have hundreds of lectures on cervical cancer. Follow me on Instagram if you would love to. I have many lectures, whatever activities and vaccination drive. I don't want any young female to die of breast or cervical cancer. So highest mortality advantage, 70 to 80% reduction, right, in cervical cancer mortality here, 20-30%. So which one is better? 80% death is reduced, 80% death is better, or reduced 20% death is better?
80%.
It is
80%.
80%, sir.
Right? Wonderful. So that is why pap smear. It is also reduced, but more compared with mammo and pap, it is more. Benefit depends on the age group and screening frequency. Important screening, but mortality reduction is less than pap smear because pap smear reduce up to 80%. This is 20 or max 30%. So if you reduce 80% death by doing regular pap smear and HPV screening, it would be great. And that is why the answer is pap smear. Colonoscopy is effective, but it also not reduces the 80% mortality, just 50%, max 60% as per the statistic. So highest is the pap smear. Pap smear prevent cancer before it start. Means it can prevent in pre-cancerous stage. Pre-cancerous stage. Mammogram detects early cancer, no pre-cancerous stage. In that, it is also important. So I'm happy now. If some female before starting the cancer in CIN, if she detects, I'm very glad. Before development of cancer, we detected and we saved the life of the patient. So this is simple but important for your knowledge. Pap smear is done for cervical. Pap smear is done for the cervical cancer, right? This is mammogram for breast cancer. What organ we do? Cervix. We are targeting on cervix here. Breast. What is the cytology? Means cell under the microscope. We are seeing in a pap smear. It is not a radiology. Nothing to do with some instrument. It is like taking the swab from the cervix, ectocervix, endocervix, cervical canal. Look it under microscope, and we see the cytology here. What we see here, mammogram is x-ray, special x-ray of breast. Screening, right? Another question in exam, what age you start screening? Number one question, 21. Second question, what age you stop pap smear screening? 65. Second question in exam, how frequently you can do pap smear? Third question in exam, every 3 yearly. Fourth examine question, if you club up with a pap smear with HPV DNA, how frequent? 5 years. Four questions I told you in one. This four question in asking exam. What age start? 21. What age stop? 65. At every 3 years, pap smear. If you club up pap smear plus HPV, 5 years. That's it. Four question. Here, 40 you start, right? 75 stops. Two question. Every 1 to 2 year. Third question in exam, right? Here, the only disadvantage of pap smear is little less sensitivity. Less sensitivity, right? Here, sensitivity is more. Specificity is almost the same, 90 to 95%. And culprit, main cause is HPV. So I strongly recommend to take vaccine against cervical cancer. And this is the only cancer where the sure shot vaccine is available globally in odd parts of the world and very economical. Your one dinner outside with your family, right, cost more than getting one shot of HPV vaccine. Let me tell you very clear cut, right? So vaccine, those who did not taken must take, give to your daughters who is 9 to 14 years of age, two vaccine dose, zero, and after 6 months, just two doses of vaccine will give you 90% plus protection against high strains of HPV like 16 and 18. This is responsible for the 50 to 60% of the cervical cancer. This two strain only. And this vaccine contains these two strains. So you must give to your daughter who is 19 to 14 and 15 to 45. There are two age 9 to 14, two dose, 15 to 45, three dose. 0 and 6 is the same, additional dose at 2 months. So in this lecture, any female less than 45 must take the three dosage today only and give to your daughter. Any confusion? Any confusion?
No, sir.
No, sir.
Wonderful, brilliant. We are going great, isn't it? Yes or no?
Yes,
My
sir.
energy is
Yes, sir.
absolutely very high. Now, last question for oncology, then our gear will be switched. If you want break, let me know. I'm unstoppable. I can speak 6 hours, but I will finish my slide. If you're getting bored, stop me, we'll stop. 50-year male with positive occult blood and family history of colon cancer. The best screening test for colon cancer is MRI, abdomen pelvis, CT scan, abdomen pelvis, colonoscopy, ultrasound. So this is really a genuine one question, right? This is one question, absolutely one question. And I have more five questions posted below. This is one question, and here the five questions. So total six question in this slide. So first answer number one question. Yes, please. Any volunteer? Yeah, so everybody is like C, so there is no difference of opinion in the house. Now, Dr. Sudesh, can you answer me one, two, three, four, and five questions answer?
So,
Are you comfortable or
sir,
looks
yeah, I
very,
will,
very,
yeah.
very looks very difficult questions?
Sir, I haven't studied
Difficult
that
really?
part, but I will, yeah. I think it's at
No
age of
problem. You study it later
45.
on.
Yeah,
You
okay.
can study later
Uh,
on. But so let me give the opportunity to another one, right? Right? Any volunteers wants to answer these questions?
So general population, you do fecal
Okay.
occult blood testing starting from 50 to 74 years every 2 years.
Wonderful. Wonderful.
And
General
for
population. Fine, fair enough. If somebody has a single family member with the colon cancer, is the guideline same like general population and one family member? So say for example, I do not have
No, sir.
anybody of colon cancer in my family. What is the screening guideline? My dad has a colon cancer and I am asking what to do for colon cancer screening. What is the answer? Is it the same answer? No
No,
family
sir.
member with colon cancer and family first degree family member with colon cancer. Is it the same guideline? If not same guideline, what is the answer? Single family member with colon cancer. What is the colon screening guideline? Three family
so
member in family with colon cancer. What is the screening program? FAP means familial adenomatous polyposis, Gardner, Put, Zager, and Turcot syndrome. What is a colon cancer screening? Somebody with a juvenile polyposis, what is the colon cancer screening? All five questions in exam, frequently asked.
so
Fine. Let me
simple.
jump.
Yeah.
Yes. So answer is a colonoscopy. 50-year-old male with positive occult blood, family history of colon considered high risk. Base screening test is the colonoscopy. Why colonoscopy? Gold standard for colorectal cancer screening. Direct visualization of entire colon. Can detect and remove the polyp like precancerous. Allow the biopsy for suspicious lesion, both diagnostic and therapeutic. Extremely important, right? So this is what the thing is, and this chart is self-explanatory. All five questions, one, two, three, four, five. So this is answer of number one, right? General population. Three things you need to know. Number one is when to start. So start is 50. Second question, when to stop? Just for your knowledge, at 75. It is not written here, but I am telling you. Stop. Second question. Third question, what is the frequency in general population every 3 years? So three things in one question. If somebody, your neighbor comes tomorrow at age of 60 and asking you, sir, I have absolutely no complaint, but I want to check whether I have colon cancer or not. What's your advice? Sir, now you are more than 50, so you start the colonoscopy, right? You do it now. If it is normal, do it after 10 years. This is your advice to the patient. So start age is 50. Now he presented to 60. So start immediately, do it as soon as possible. If normal, then after 10 years. Right? What you do to know the colon cancer? Colonoscopy, highest sensitive and specific. Now the change of the scenario. Right? Here, general population, no family member has cancer. No family member has colon cancer. Absolute healthy family. Now somebody's single family member with colon cancer, how the management will change? Screening start at 40. See now 40. First question here, screening start at 50 means what? If you have one family member, right, with the colon cancer, start 10 years early, 10 years early, 10 years early. Are you getting me? Yes or no?
Yes, sir.
Yes,
Right?
sir.
So 10 years early. Answer is change in the exam. Not 50 now, 40 now, or 10 years early. Right? Colonoscopy up to 75 years. Same thing. What change is start age? Third scenario, not one family, three family member has a colon cancer. There is a two generation they have a colon cancer. Two generation, right? Have colon cancer, and somebody is very young, less than 50. What to do? Less than 50. What to do? Right? So the see the completely change, right? Colonoscopy where you start here, general population 50. one family member 40 and three family member, my God, 25 years of age. You have to start. Starting age is 25. Here 10 years. General population every 10 years. One family member every 10 years colonoscopy. Now here see, very horrible. Every 1 to 2 yearly you have to do colonoscopy. Are you getting me? Yes or no?
Yes, sir.
Yes, sir.
This,
Perfect.
this is third scenario. Fourth scenario. Four things. Familial adenomatous polyposis, Gardner, Putzager, Turcot. See, here 50, 40, 25. Now here you see the start age is 12. Oh my God. 12
Mm.
years of age you have to start sigmoidoscopy. Here 50, here 40, here 25 and here 12. Can you see how the
Yes.
guideline change? Why? This is like a atom bomb, nuclear bomb. 100% they will develop. It is one of the high risk. If you have out of these four, familial adenomatous polyposis, Gardner syndrome, Putzager, Turcot, they will definitely going to develop the colon cancer. And that is why you have to start at the age of 12 and doing it every 1 to 2 year to detect in early stage. It is a screening program. It is a screening. So earlier the better, right? So depends. So somebody's general population asks, you can't say, oh, every 1 to 2 year you start at 12 years of age. Wrong answer. It is for this only, high risk patient. General population, start 50, stop 75, do colonoscopy every 10 years. Here, do sigmoidoscopy, start at 12 years, every 1 to 2 year you do it. That's it. And juvenile polyposis, no extra screening recommendation. It is as good as number one, general population. Start 50, stop 75, every 10 years, what you do? Colonoscopy. That's it. Are you getting me? Yes or no? I want at least yes or no.
Yes, sir. Sir, I just wanted to ask, in the
Yes,
second one, a
please.
single family
Yes,
member
sir.
has colon cancer, and
Yes, sir.
that person is detected at 37 years of age. Okay. So should the
Yes.
other family member uh, uh, do this at
No,
screening at
so start at
27?
27.
27, right?
27. Earlier the
Okay.
better. Either 40 or 10 years early. See,
Okay.
guideline what says, sir? 10 years early than the age at which the family member contracted the cancer. So
Okay.
somebody say, for example, father got 40 years, at the age of 40 years, there is a colon cancer. Father got,
Mhm.
right? And now son
Okay.
is asking, sir, when I supposed to start colonoscopy at 30 years? 10 years earlier.
Okay. Yeah, that's what I wanted to ask.
Is that clear?
Yes, sir. It's clear now.
Right? So either 40
Okay.
or the age where the first family member acquired. Say another example. Father developed at the age of 60 years, colon cancer, right?
Mm.
So before 10 years is 50, but 40 and 50 earlier is 40. So start at 40. If
Okay.
father got at 60 years of age, start at
Mm.
40, right?
Right.
But if father got at 45 years of age, then don't start at 40, 10 years earlier,
35.
35.
Okay, sir. Okay, sir. Now I got it.
Any questions, confusion? Any questions to the audience? Right, so we answered all the questions, right? One, general population, single family, three family, this all high risk juvenile polyposis. This is the brilliant chart. A 40-year-old woman present with abnormal cervical cytology on pap smear suggestive of CIN3, cervical intraepithelial neoplasia. The next best step in the management is hysterectomy, colposcopy leap, colposcopy and cryotherapy, observation and regular yearly pap smear. What is the answer? Post your answer in the chat box. Absolutely high yield questions. Every paper has these questions, believe me. Yes, Dr. Mifra, what's your opinion? Yes, anyone? Dr. Abhay,
So I would go with colposcopy and leap.
colposcopy and leap. So what is leap?
Yes, sir.
What is leap? What is the
Uh,
full form of leap?
Loop
Sir, it's
electrosurgical excision procedure.
Let
loop
her answer and what
electrosurgical excision procedure.
just me, Fred. You got it.
yes, sir.
So our job is not just to get the name leap, but we need to know the full form of leap as well. So tell me, Dr. Mifra, if you don't mind, what is CIN1, CIN2, and CIN3? How they different one from? So when you say CIN1, CIN2, and CIN3, what's the understanding in your mind? Is it radiological
So
investigation?
CIN1 is no, sir.
Yeah, you
It's
go
a
ahead,
cytological
right?
investigation.
Wonderful. Cytological. By doing the PEP, we know that it is
So
CIN
it's
1, 2, 3, blah, blah, blah. Wonderful. So how you differentiate 1, 2, 3? Do you have some definition in your mind? If I ask
yes, sir.
you, how you
CIN1
differentiate
is
between
only the 1/3 of the
what is one third? One third of what?
Sir, I think the amount of abnormal cells are more like
Wonderful,
that.
brilliant. So amount of abnormal cell, do you quantify? 10%, 20%, 30%, 100%? Specific
Um,
question I am asking you, Jay, right? Just to bring the
yes,
more clarity.
I think, sir, 20 to 30%. I think,
Okay, so
like in
CIA1
one,
is
like in one
CIN1 is
20
20
30.
to 30%.
Yeah,
Sorry, CIN1 is 20 to 30%. Then what is CIN2?
I think it will be doubled, sir.
Okay, and what is
2/3, sir.
CIN3?
230. Yeah. Hmm?
Okay, what is CIN3 then?
Sir,
It
I think
is
it will full, sir,
full thickness.
The
full
Full
thickness.
Sir,
thickness.
thickness, sir.
CIN3 base up to basement membrane.
Up
CIN3
to basement membrane. And what is invasive carcinoma?
it's
In
involve whole cervix and
Involve
extend
the
up.
whole cervix. Wonderful. So first, get the clarity of CIN 1, 2, 3, 4. You will never ever forget. This is cervical intraepithelial neoplasia, right? Simple. So this is cell normal. This is absolute normal cell, right? So this is round. It is normal cervical squamous, say for example, cell.
Hmm. Okay.
Because of the biggest culprit, can anyone tell me which is the biggest risk factor for developing from this side to this side? What is the biggest risk factor for development of cervical cancer?
HPV, sir.
Biggest, brilliant, HPV,
HPV.
right? So we have two things. We can detect HPV very early stage. We have tool HPV DNA and pap smear, and we have vaccines as well.
Hmm.
We must do both the things. It is not alternate to one. You have taken vaccine means you don't need to do pap smear. Absolutely wrong concept. If you are doing the regular pap smear, you don't need vaccine. Absolutely wrong concept. These two both combined will reduce more than 90% of the risk of cancer, right? Or mortality in a female. So this is normal. Lower one third is involved, CIN1. Lower two third is involved, right? And almost whole thickness is involved. The beauty is basement membrane is intact. CIN1 2. Here see the basement membrane is broken, and that is why it is called as an invasive carcinoma. Are you getting me? Yes or no?
Yes, sir.
What is the goal here? It is very basic concept, very important. CIN1, 2, and 3. Our main goal of doing the regular pap smear or HPV DNA to detect in this stage, not in this stage. You understand? Here you can prevent. Here you can
Hmm.
cure. You cannot prevent. No? Once cancer is developed, somebody is with cervical cancer. Now what you prevent? Nothing. You have to cure now. Here you can prevent. Are you getting me? Yes or no? What you
Yes, sir.
prevent? You prevent them to go into the cancer. And here the pap smear has a role. Here the HPV DNA detection has a role. That is what we want to educate the female globally, that do the pap smear regularly every 3 yearly. If alone pap smear, if pap smear plus HPV DNA every 5 years. This is guideline. Are you getting me? Yes or no?
Yes, sir.
Yes, sir.
So here treatment will change. Here
Mm.
treatment is different. Here treatment is different. Here treatment is different. And here treatment is absolutely different. That is why we need to know this concept. What is CIN 1, 2, 3, blah, blah, blah. Is everybody's clear for this picture? I think I don't explain you easier than this. Is it clear, Jay? I mean, what
Yes,
is
sir.
the, so it is not
Yes,
on
sir.
the percentage. It is not on the
Okay.
Yes.
percentage. It's involved on the thickness. How the cell involved, right?
Okay.
1/3, 2/3, more than 2/3 or this. So if you take a picture of this and you keep
Okay.
it with you, it is there available online. I just try to make my presentation simpler. That is why I bring lot of picture to bring more clarity. Right? So this
It's
is
like
what how
precancerous. Okay,
sorry,
okay, sir.
madam.
I just wanted to say that like it's like precancerous stage, right?
Yes, so
Scene one,
this
two,
is
three.
normal. So,
Mm.
so sir, this is normal, say, right? So we are not worried about this. But how did we get to know? By doing regular pap smear at 3 years? If we are getting this, we are happy.
Mm.
But what happens every 3 years, right? 2026 this,
Mm.
2029 after 3 years this, after 3 years 2032 this, means we are not going well, right? We are going towards. So maybe in 2035 we have a full-fledged cancer, right? So within,
Okay.
and this you from this to this, overall literature world over says it takes 10 years, especially for those patients who have HPV positive,
Okay.
right? So we don't need to go into this stage, and that is why we need to counsel our sister, our mother, our cousin, our near and dear, every female in the world to go for pap smear. Is that clear? Is that
Yes, sir.
clear? Wonderful, right? So if something is there, here the treatment is very easy. Here treatment is very easy. Here is just the observation. Here no need to do nothing. We don't need this. Are you getting me? But how we
Yes, sir.
supposed to know? Without pap smear or HPV DNA? Impossible. Impossible. And let me tell you, being an oncologist, symptoms are up to this symptoms zero. No white discharge, no false smelling discharge, no excessive menses, no intermenstrual bleeding, no postmenopausal bleeding, no bleeding postcoital, no urinary or bladder complaint. Open up the book. These are the all cervical cancer symptoms, which is zero here. And that is why female feels I'm safe, but she is in CIN3, asymptomatic. We need to pick up that. Is that clear to everyone? Yes or no? At least tell me yes or no.
Yes, sir.
Yes.
Yes, sir.
Yes, sir.
Let's jump back to the question. So now we got the clarity. So CIN3. So now everybody has clear cut concept that sir, what is CIN 1, 2, 3 and cancer and normal. Right? So now
Mm.
let's go back and jump to the cancer. So obviously, if you are going towards this, is bad news. Just for your knowledge. So some female is normal after 3 years. If she is CIN2, means it is bad news. If you are going towards this, it's bad news. And in advanced stage, that's it. We don't need to go from this to this. Stop it here. How we stop it here? By screening. That's it. Only one way globally, right? But if you have this, treatment is bit difficult or little this. So this is the understanding. Now let's jump to the literature and our concept. What we supposed to do for this? So CIN1, as I told you, lower 1/3, CIN2, lower 2/3, and full thickness, right? Is that clear? Yes or no? This is low
Yes,
grade
sir.
squamous intraepithelial neoplasm. This is high grade squamous intraepithelial lesion. Cancer risk very, very low, rather, I can say. Here, or you can say mild or very low. Here, moderate. Here, high. And after that, invasive carcinoma of cervix, squamous cell, most common. 70% develop squamous cell, 30%, 20-30% develop adenocarcinoma. This is a cervix, right? So inner part of the cervix is endocervix and ectocervix, where they both meet transformation zone, right? So 70% as a squamous, 30% endocervix, they have adenocarcinoma. So common, just for your knowledge. Exam question. Management, right? So management is what? What happens to my internet? Management, observe here. Observe here. Here the leap. Here also leap plus conization. They are asking the CIN3, what is the treatment or management? Answer is leap or conization. Is that clear to everyone? So here what is the answer? Right? Leap or conization. Here they had given leap. So that's fine. You do the colposcopy and leap. Is that clear to everyone?
Yes, sir.
Yes, sir.
Leap. So a pap smear suggestive of CIN3, cervical intraepithelial neoplasm grade 3 means whole thickness, lower 1/3, lower 2/3, whole thickness, CIN3. Represent high grade precancerous lesion of the cervix. Colposcopic evaluation to visualize the transformation zone. What is transformation zone? Where the endo and ectocervix meet, transformation zone. Excisional treatment, right? You have CIN3. Next stage is immediately cancer, invasive cancer. Basal membrane is ruptured. So before it go, you do something. Loop electrosurgical excision. You completely remove it. Why leap? Removes the entire transformation zone, which is the highest risk of developing the invasive carcinoma. Remove it. Provide histopathology because you see it under microscope, and it is not just the therapeutic, it is diagnostic as well. So both things will be solved, diagnostic as well as therapeutic. Why not hysterectomy? It is too aggressive for CIN3, right? Why not cryotherapy? Cryotherapy is usually for low lesions, CIN1, and it does not provide the tissue pathology as well. Like FNSE does not provide the this tissue to perform ERP or HER2. Same way, CIN1, if you do cryotherapy, right, it just treat the problem, but you cannot study the pathology of the tissue under microscope. Conization used when lesion extend to endocervical canal. Colposcopy is unsatisfactory and suspicious of microinvasion where you do the conization. Otherwise, standard treatment is leap. You remove it. That's it before invasive cancers develop. So last but not the least, CIN1, observe it, usually CIN2 or 3, excisional loop, right? Excisional procedure, electrosurgical, and invasive, only surgery if it is early stage, stage 1, and beyond the stage 2, now chemoradiation, no role of surgery. So 95% of the cancer we treat in our center every day is with chemoradiation, right? Because very early stage, right? Like stage 1A and 1B, where you offer the surgery to the patient. Otherwise, usually in India, we have patient usually present in stage 2, stage 3, or stage 4. If I see 100 patient in a year, every 10 patients I'm seeing cervix. So in 1 year, 100 patient, I hardly get 2 patient who is in stage 1, and almost no patient in CIN. Almost no patient in CIN. Why? Because people are reluctant for pap smear. And without doing the pap smear HPV, I cannot detect in CIN. There is no way to know CIN without pap smear. So what is the take home message? Right? Tell and educate each and every female globally for the pap smear. Any question? Jay, are you clear?
Yes, sir. Got it.
Any confusion?
No, sir.
Anybody has any question?
Sir, in some questions there is Oscars positive with that. Can you kindly describe little bit about it?
What's the question?
some questions I read questions from your website. Some questions there is the some oscus positive, oscus negative. Can you give some concept regarding to this?
Yeah, so not difficult. So that is again a very important thing. Wonderful. So this is normal. You did a pap smear for the female. Atypical squamous cells of uncertain significance, something like that, right? If I'm not wrong,
Yes, sir.
atypical squamous cells of uncertain significance. So there are three category. So you did a pap smear and they reported it is Oscars. Everybody go and read it. Huh? It's an important question raised by Dr. Rabia. It's a exam question. So you did a pap smear in a normal individual as a part of routine every 3 yearly. Last year she has normal. Again, that lady comes. It's her 3 years finish. I want to do again 3 years, right? Earlier normal. Now she has Oscars. Three possibility. It's a part of normal variation. It could be some kind of infections or STD, and it could be cancer. There are three possibilities, isn't it? So every Oscars does not mean cancer. Number one, that you have to fix in your mind. So once you have Oscars, the biggest thing as per most of the guideline is to do HPV. Why?
Okay.
HPV is the culprit for cervical cancer. So say for example, today any female turned up Oscars, you did HPV. There are two possibility: HPV positive, HPV negative, isn't it? Yes or no?
Yes, sir.
If HPV is positive, you have some abnormal cell, go for colposcopic and biopsy.
Okay.
If HPV is negative, very rarely without HPV you get the cervical cancer. So in that case, once you have Oscars, instead of 3 years, you do it at 1 year, just to make sure that you are not missing anything. Say for example, Oscars will convert into CIN 1, 2, 3, isn't it? Yes or no? Right? So you do it bit closely, right? And if it is negative, you continue it. 2 or 3 years it is negative, then you do every 3 yearly. Are you getting me, Dr. Rabia?
Yes, sir.
Any confusion? Did you
Now I
get your answer or not?
yes, sir. It's clear now.
Wonderful. You are very brilliant.
Thank you.
Wonderful. So that's all for cervical cancer. So leading cause of death globally, right? That is why I stretch little bit for breast. So number one cause of death in female due to cancer is number one breast. So male and female both needs to know we need to reduce the death in female for breast cancer. So you need to know each and everything: mammogram, FNA, biopsy, how frequently, what is the result. Then there is another we will discuss sometime, BIRAD score. We need to know BIRAD score, breast imaging radiography and data system. So BIRAD score is mentioned from 0 to 6. What is 0, 1, 2, 3, 4, 5? So I request each and every doctor to read everything in detail in breast cancer, because number one killer in female and number two killer is cervix. Indian statistic, every eight, every one, right, every 1 hour, eight female dying, means in 24 hours, 200 females dying. In 365 days, 75,000 plus female are dying. This is latest data of Indian origin. And we need to reduce this. We need to. Likewise, in Australia, in Australia, right, this 75,000 is just like a thousand, only thousand. And by 2020-30, it is zero. This is what the projection. This would be the number one country in the world who is cancer free of cervical cancer, Australia. Only reason, three things, right? One is awareness and education, what I'm doing to you. Second is vaccination. And third is pap smear and HPV early detection. That's it. So if any country implement these three things, they can be in next 10-20 years cervical cancer free. they become. Is that clear?
Yes.
Would you like to discuss one more questions of hematology, or you are tired?
Go ahead, sir. Go ahead, please.
Wonderful. I think all everybody is energetic, but I can see the quality of the voice is going down because of hypoxia or hypoglycemia. I don't know.
No, no, sir, you can continue.
No, sir. No, sir.
Thank you. Yeah, I'm also hungry, but my energy level is quite good still. Okay, so I think we'll discuss one last questions, and which is, and then we'll continue the session of the next week. The same hemat-oncology will continue. We'll finish it. Many questions. Here, make a huge list of leukemias. Ask me all. I will discuss this question for next 15 minutes and then pack up. All questions, weird questions. Don't think that, oh, this is silly questions. Ask me anything. I would be happy to answer you. So ask most complex things. 66 years old man comes to physician for 1 week history of fatigue. He has hypertension and hyperlipidemia. He had a transient ischemic attack 3 years ago. He drinks 3 beer a day, sometime a couple of more on social occasion. He currently takes aspirin, simvastatin, hydrochlorothiazide, metoprolol. His temperature is 37 degree, pulse is 78, respiratory rate is 19, oxygen saturation on room air is 97%. He is not apparently in any distress. Physical examination show conjunctival pallor, multiple pinpoint red non-blanching spot on his extremities. On abdominal examination, his spleen is enlarged. Laboratory studies shows a hemoglobin of 8 gram percent. Leukocyte or WBC count is 80,000. Platelet counts of 34,000. A peripheral smear shows immature cells with large prominent nuclei and elongated needle-shaped cytoplasmic inclusion. What is which of the following is the most likely diagnosis? AML, that is acute myeloid leukemia. ALL, that is acute lymphoid leukemia. CML, that is chronic myeloid leukemia. CLL, that is chronic lymphoblastic leukemia. MDS, myelodysplastic syndrome. Blah blah. Hundreds of questions I can ask on this. But first, decide. I have seen those who follow this triad, they have more success ratio in the exam than any other category, right? By my experience of last 12 years of coaching in these industries as an expert, this triad, if you forget, high chance of failure. Every MCQ, 3 questions you have to answer. So there, what they are asking, diagnosis. So now first make this, then we'll jump on this. Yes. Last question. So maintain some energy for next 10 minutes. Discuss it well. What do you think? Just tell me, and why you want this. We want to differentiate everything one from another. Yes, Dr. Mahil. Any comment, Dr. Mahil?
Sir, this is Mifra, sir. My got lost connection, so I came in the other phone.
No
Sir,
problem.
my answer is AML. As
Okay,
it
so
says needle
wonderful, brilliant.
inclusions, that
Mm-hmm.
is suggestive of oral rods, which is
Wonderful,
specific for AML, sir.
wonderful, brilliant, brilliant. See the very brilliant lady. So this is a nuclear a cell, nucleus, and there is a elongated. I'm reading this. This is immature cell. So leukemia has immature cell, right? Not mature usually in acute leukemia. Prominent nucleoli, prominent nucleoli, elongated needle-shaped cytoplasmic. So this is cytoplasm, elongated, long, needle-shaped inclusion. This is none other than OR rod. It's a description of OR rod. And fix in your head, OR rod is equal to AML. It cannot seen in ALL. It cannot seen in CML. It cannot seen in CLL. it cannot seen in MDS. So this lady is a very smart lady who answered just or rod AML. Simple. Whatever is there, you read, you don't read, whatever they had given, simple. Or rod is equal to AML. Is that clear to everyone? Yes or no?
Yes, sir.
Yes, sir.
Brilliant, brilliant. So this is AML, right? Now, can you tell me, doctor, AML? Can you describe AML? How many subtypes? So AML is a diagnosis, acute myeloid leukemia, right? So how much percentage of blast should be there in AML? 1%, 5%, 10%, 20%,
20% then
20%,
20%.
20%.
20,
More, more,
20.
more,
20.
one,
More than
more
20.
than 20.
50%.
wonderful. 20% blast cell is acute leukemia, right? So this is basic things, right? So
Mhm.
let me give you the more clarity on this, then we'll discuss a lot of concept base. So whenever you have leukemia, right? Leukemia can be classified on two ways. One, how speedy they develop, and because of speed, it is called as a acute, and slow speed chronic. Are you getting me? Yes or no? This is
Yes, sir.
one way.
Yes, sir.
And cell
Yes, sir.
line involved, cell line involved. If myeloid, then myeloid leukemia. When lymphoid, then lymphoid leukemia. Is that clear? Yes or no?
Yes, sir.
So there are four entity: acute myeloid AML, acute lymphoid ALL, chronic myeloid CML, chronic lymphoid CLL. Is that clear? Yes or no?
Yes, sir.
Yes, sir.
Brilliant. So there are two acute leukemia which develop speedy, and myeloid and lymphoid, chronic two leukemia, myeloid and lymphoid, right? So there are four major entities of leukemia. So this is one concept basically, right? What is the another concept you need to know? This is a cell. This is a hematopoietic stem cell, which gives rise to two things. One is a myeloblast, another is lymphoblast. Lymphoblast just give rise to three things: T lymphocyte, B lymphocyte, natural killer cell. That's it. This myeloblast give rise to everything, right? Erythroblast, erythroblast eventually develop RBC. Megakaryoblast, megakaryocyte, eventually platelet, right? And also it can cause the all right? So RBC is formed by myeloblast, platelet can also, and WBC also, except lymphocyte, means neutrophil, eosinophil, basophil, and monocyte, all by the myeloblast. So what is done by the lymphoblast is only lymphocyte. That's it. So if it is something goes wrong in the stem cell at myeloblast, it is myeloid leukemia. Something goes wrong at the lymphoblast, lymphoid leukemia. If there is a more than 20% of myeloblast, it is acute myeloid leukemia. If it is more than 20% of the lymphoblast, it is acute lymphoid leukemia. Are you getting me what I'm trying to explain in a most simplest way?
Yes,
Yes
sir.
or no?
Yes, sir.
This is so this tree is absolutely important to know the basic things. Otherwise, nobody can understand leukemia. So we see all four subtype, speed and lineage, right?
डन
Now,
कर दो
if you,
पापा सो गए हैं क्या
so so
बंद
here
कर
the
दो
cells are, if you are going from here
तो
up
रेस्ट
to
कर लो फिर
down,
4 बजे क्लास जाएगी मायरा
1 minute, let me mute all.
नहीं बेटा जाना है फिर मैम छुट्टी पे चली जाएंगी ना
Okay, right? So I muted all just to avoid the disturbance to me. If you are going from here to here, premature to mature cell will happen. Premature to mature. One example, right? Myeloblast, if this cell lines is developed, myeloblast, promyelocyte, metamyelocyte, band cell, and neutrophil. This is the cascade. I bypass this just to make it bit easy. So this is the complete from myeloblast, promyelocyte, metamyelocyte, myelocyte, band cell, and then mature neutrophil. So if you coming from up to down, immature to mature cell will develop. So premature cell is morely seen, and premature cell is named as blast. So premature cell is seen in acute leukemia. Earlier precursors involved myeloblast. You cannot see here myeloblast here, right? So acute leukemia, either myeloid or lymphoid, you have premature cell. Chronic leukemia, you have mature cell. Acute leukemia, you have more than 20% of blast. Chronic leukemia, you have less than 20% of blast. Acute leukemia, they are more sick. Chronic leukemia, they are stable, walking, talking, moving around. Right here, they are young and middle-aged patient. Here, elderly patient. This is the major difference between acute and chronic leukemia. Right? Which you must know. Absolutely, you must know. Right? And there are lots of questions with this as well. Right? So this is here. The answer is AML. Why? Because OR rod. That's it. If you remember this OR rod. Right? Otherwise, everybody ALL also present with the pancytopenia. But what is the age in ALL? Not 66 years. It is in the children, pediatric age group, usually less than 10 years. Right? It is 60 years. So by that way, age is also important to differentiate. Right? Now we have 6 questions. Best prognosis of all AML subtype. There are 8 subtype M0 to M7. If somebody wants to tell the name, I'm happy. Which is the commonest AML all subtype? DIC common presentation in which AML and why? How to categorize AML by risk factor? How to treat high risk AML? What is the ATRA and where does it use? Lots of exhaustive question, isn't it? So let's see. There are M0 to M7 subtype, right? In AML. I'm not trying to make you hematologist, but it's important for you to know basic exam point of view. If you see highest or most common, so most common is AML M2. If somebody asks you which is the most commonest, there are 0 subtype to 7 subtype of AML. Minimal differentiated, without maturation, with maturation, acute promyelocytic, myelomonocytic, eosinophilic, myelomonocytic, erythro and megakaryocyte. So number one question, if they ask which is the most common amongst M0 to M7, this is the answer, most common. Let me write down. Second question, which has the best prognosis among M0 to M7? This is the second answer. Second answer, most prognostically based. Who has the highest cure rate than M3? See, most common does not mean it is highest cure rate, right? So second, third question, which AML present with the disseminated intravascular coagulation? Again M3, it is commonly present with severe DIC, which is not the case in M0 to M7. Third question in exam. Fourth, right sir, you told me this has a best prognosis, then which has the worst prognosis? Question number 4, worst prognosis, AML M7, megakaryocytic leukemia, worst prognosis. Which leukemia associated with the Down syndrome? Fifth question. It is the question M7 associated with the Down syndrome. Likewise. So this is little sixth question. AML M3, which is a drug of choice? Right? Drug of choice. ATRA. What do you mean by ATRA? All trans retinoic acid. All trans retinoic acid. It's a vitamin A derivatives which helps the myeloblast to mature to neutrophil and cure the leukemia, right? So these are like several questions is there in the exam, but I'm just highlighting on the common clinical questions which they usually ask you in the exam, right? So you can get the whole PowerPoint on our YouTube channel. So I answered all the questions here. Best prognosis of all AML M0 to M subtype. I told you already told you which one has the best prognosis. M3. The popular name of M3 is APL, acute promyelocytic leukemia in many books. APL, acute promyelocytic. Commonest M2, not the M3, right? This is right. So APL, right? What is the best prognosis? Commonest is M2, 30%. So if you see the 100%, 100 patients of AML, 30% is like the AML M2. DIC is common presentation of M3. I already told you. APL, DIC, ATRA, high yield point, all trans retinoic acid, treatment of choice. How to differentiate AML risk by WBC count, by cytogenetic, by molecular test. How to treat high risk AML, chemotherapy, right, followed by allogenic bone marrow transplant, right. So transplant is one of the treatment for high risk AML, right. And what is ATRA and where it used? All trans retinoic acid, vitamin A derivatives. It is used in AML M3, and there are hundreds of questions in AML, right? So probably I need one whole 2 3 hours lecture for AML only, but we'll see sometimes in detail in my another hematology lecture. So I think that's all. I probably stop it here. So this is AML. Next time we'll see ITP, von Willebrand disease, or some coagulating clotting cascade, which looks very difficult to lots of students. Intrinsic pathway, extrinsic pathway, where Clexane, when newer oral anticoagulant, warfarin, dabigatran, right, apixaban works. I will teach you, right? So it's a very interesting sessions together. I have hundreds of points in my mind to teach you hematology. So thank you very much all for joining me, listening me coolly and calmly. So before I end up my session, usually I get little quick feedback. How did you enjoyed really the way I enjoyed? How did you enjoyed and what's the learning? I need to get from something new. People who joined me the first time in hematology, like Joy or someone who joined first time, who is listening me first time. So I need your feedback. How did you enjoy?
Sir, I like the interaction between teacher and the student, and how you were easily explaining all our doubts.
Wonderful, sir. Thank you for your feedback. Any other comment?
Yes, sir. Like I understood every doubts clearly. First, I couldn't like I. This is my first time in the class, and I enjoyed it
Wonderful.
because yes, I can ask the questions. I got the replies, and I understood also. Yes,
Wonderful. So I would like to be in the coaching soon. So
yes,
that will probably brings lots of clarity to the concept, right? And once you know the concept, you can answer any
mm,
question. That is what I believe. Isn't
yes,
it?
sir. Yes, sir.
Wonderful. Thank you for your feedback, Jay. Yes. Anyone else? Doctor,
Sir,
no problem.
I'm Sudesh here. Yeah, I think
Yes,
you
Suresh.
explained everything very nicely, especially when you sum up everything at the end of the question. It was very clear, and you targeted question towards exams. That is very helpful, and you emphasize things that has we have to learn also. So thank you very much. It was a wonderful session. I will join in
Thank
future
you, sir.
also.
Thank you very
Thank
much
you
for
very
the
much.
kind feedback, sir. Yes, sir. Anyone else? Something new learning? Yes,
Very
Saranya, I think you
informative
are.
class, sir.
Yes.
Thank you very much for the class.
No problem, Sarnas. Thank you for your kind feedback. This is every day, every Sunday, so don't miss out.
Yes,
Sir,
sir.
plan next class
Next Sunday.
soon, please.
Yeah, I'll try my level best to catch it bit early, doctor. But because of time and
because
practice, it's
because because we want to complete these all things like
yeah. So what
leukemias
you
and
can do, Doctor
DIs.
Rabia, read whole hematology for 1 week and get the most difficult questions for me.
Sir, this
Not
is my
you,
Eid
not you,
week. It's
everybody. Everybody, you have 1 week of time to get a difficult questions for me. I try my level best to answer you. If I don't know, I will open up the book and guide you. But I want you to read. Until and unless you read, how did you get to know what is the question, what needs to be asked? Because you are blank. So how you gonna ask me the questions? To ask the question, you need to read. Yes, Saranya, any
okay.
comment?
Yes, sir. Good afternoon, sir. Wonderful
Very
class,
good
sir.
afternoon. Did you there in the class from first to last or in
No,
between you
sir.
had a
Like I joined in between, sir,
no
and
problem?
due to my circumstances, I couldn't fully attend the class, sir.
Fair enough, but you can catch it on YouTube channel,
Yes, sir. Sure, sir.
right? Whatever is missing. Fair enough. Yes.
Yes,
Anyone?
sir. Thank you, sir.
Lastly, you're welcome. Last comment, anything you learned something new or motivated you or it changed the way of perception or breaking the MCQ and dissecting the MCQ? Yes, fine. Thank you very much. So I'll end up the sessions and keep in touch. Stay tuned. Do let me know, right? If you need any help, just let me know and prepare well for the next session. We will discuss all rest of the important high yield hematology more. Thank you very much and enjoy your day. Thank you.